Hi, this is Heather Martin, and I'm going to be covering some of the information that is covered in the 21st century maternity nursing, and we'll be covering some of the concerns with health disparities and some of the things that stop women from seeking out early prenatal care or any care for their general health concerns. We'll be touching on some of the Healthy People 2020 goals that have been set, as well as the overview of what some of the health problems in our healthcare system is for our patients and some of the maternal-infant biostatistics. So as we look at the lack of access to pre-pregnancy and pregnancy-related care for women, this continues to be a major concern. Some basic definitions for you. With mortality, worldwide, there's approximately 800 women that die each day due to problems related to pregnancy and childbirth. And the key is reducing this, and the way that our goal is to reduce this is to enhance the access to prenatal care. There's three major causes that have been linked with mortality, and that is the hypertensive disorders, infection, as well as hemorrhage. This can also include an unsafe termination or abortion, which has also been listed as an additional factor. With maternal mortality in the United States, we also have this related to the gestational hypertension, which we'll be elaborating on later in our course, pulmonary embolism, and again, hemorrhage. For the factors that strongly relate to maternal death, they have ages that are younger than 20 or patients that are over 35 years of age, if they have lack of prenatal care, if they have low educational status, as well as if they are unmarried, and also non-Caucasian. For morbidity, this is really a measure of maternal health, which is often measured in our neonatal outcomes in looking at pregnancy complications. With maternal morbidity, the results are high in our risk pregnancies, and that would include patients who have acute renal failure, amniotic embolism, or pulmonary embolism. And something to keep in mind is that these result in a situational crisis. We also know that obesity is a major concern for our entire population in the United States, and we know that obesity affects women, and statistics show us that it's about a third of the women in the United States have a BMI over 30. And this is affected by racial disparities, and that is about 50% are non-Hispanic Black women that are most affected. And with about 20% of women who give birth in the United States, they are listed to be obese, and this does have a direct correlation with risk factors, making it a high-risk pregnancy with the hypertension as well as the diabetes. With obesity, it's also been linked to a decrease in fertility. There has been an increase in congenital anomalies, as well as for increase with miscarriages and fetal death. With our patients who are obese and are pregnant, it can increase the amount of healthcare services that they seek out and may require longer hospital stays. For the significant disparities with morbidity and mortality when compared to Caucasians, it's highly indicative in patients that are of African American descent, Native American, Hispanic, Alaska Natives, as well as Asian Pacific Islanders. These populations are known to have shorter life expectancies, and they have higher infant and maternal mortality rates, including higher rates of birth defects and a higher incidence of sexually transmitted infections. And this can be caused from environment and the complexity in it, as well as their health or lifestyle behaviors. And these disparities in education also will have a direct effect for these clients, as well as their income, which will also influence morbidity and mortality. So taking a look at Healthy People 2020, it continues to have a list of goals, and With the maternal, infant, and child health focus, there's approximately 33 that are directly related to this. Because we know that this is a problem in the United States healthcare system, we're looking at the structure of our healthcare delivery system. We know that it's fragmented as well as expensive, and we also have the consumer participation in healthcare that is increasing. They're being included in their decision making. They're utilizing internet care, anything from Ask a Doctor to Ask Dr. Google. We know that we live in a very technology-driven and intensive environment. So these things all have impact on the structure of our healthcare. The goal that some of the things we're looking at is reduction of medical error. These are leading causes of death in the United States and result in approximately 100,000 deaths per year. Looking at high cost of healthcare, we know that it is affected by higher spending in the United States when we compare it to 12 other industrialized countries. We're looking at higher prices. We're looking at the accessibility technology, as well as that we have greater obesity. With this, it is largely impacted due to caring for the number of babies that are born as low birth weight babies and are being cared for in our neonatal intensive care unit. Some of these babies are in there for a short time, few days to a week. Other babies are in there for sometimes multiple months. Some of the things that have changed in healthcare is that they are using across the board many more mid-level providers, which include nurse practitioners as well as nurse midwives. And these healthcare providers help contain some of the healthcare costs. The complication or the drawback is that not all insurances will reimburse for care from these mid-level providers, so that is something that is very specific based on the patient's insurance. Patients with limited access to care, we need to continue working on removing barriers to help facilitate regular prenatal care, and ideally, these patients should be receiving care long before they even achieve pregnancy. So regular just maintenance of their general annual Pap exam, labs, if they need to have any other testing done on a routine basis. And with this limited access to care, this also is an insurance coverage issue. They may have insurance and they may have spend down, meaning that they may be responsible for the first $500 per month. So once they meet that $500, for example, at that time, then anything afterwards would be covered. And so you can see that this would become very costly because that $500 would then reset every month. And the significant barrier to this is the patient's inability to pay. So some physicians limit or they even decline seeing patients that are on any kind of the Medicaid, and the patients that they do care for may have more privatized insurances. And certainly the patients that aren't being seen due to the Medicaid, we see statistically have a significant proportion of the births that may have the higher risks. We also have transportation as an issue for many patients, getting to their appointments. And with this change that President Obama signed in 2010, with that healthcare reform, healthcare is really under some significant changes and is allowing patients to be seen and to receive care. It's the transportation that does still seem to be an issue, and when we have our patients there in our office or in our setting, it's taking advantage of as much education and teaching that we can at each opportunity. As we referenced 2020, we know that there used to be a 2010, and there also used to be a Healthy People 2000. Due to some of these unmet goals, we've seen that direct impact continue on our maternal as well as morbidity and mortality rates, fetal and infant loss, including long-term health problems. Some of the biostatistical terminology that we'll see noted, especially in our evidence-based practice and in review of literature, is some of the terms that I'll go through now for you. One is the abortus, which is the embryo or fetus, which is removed or expelled from the uterus at 20 weeks of gestation or less. Weight would be under 500 grams, and it measures less than 25 centimeters. Birth rate is the number of live births in 1 year per 1,000 population. Fertility rate is the number of births per 1,000 women between the ages of 15 and 44, and that's calculated on an annual basis. Infant mortality rate is the number of deaths of infants younger than 1 year of age per 1,000 live births. The maternal mortality rate is the number of maternal deaths from birth, as well as complications of pregnancy, childbirth, and puerperium, and that's the first 42 days after termination of pregnancy per 100,000 live births. Pregnancy-associated deaths include all deaths during pregnancy and within 1 year following the end of pregnancy. Pregnancy-related deaths, so this is a subset of pregnancy-associated, and these deaths that are complication of pregnancy or aggravation of an unrelated condition due to the pregnancy or is a chain of events initiated by the pregnancy. Neonatal mortality rate is the number of deaths of infants under 28 days of age per 1,000 live births. Perinatal mortality rate, which is the number of stillbirths and a number of neonatal deaths per 1,000 live births. And then stillbirth is an infant who at birth demonstrates no signs of life, which would include breathing, a heartbeat, or any kind of voluntary muscle movements. I think this slide does a great job showing us some of the things that needs to be considered in the effects for our patient who's pregnant, as well as the outcome of her pregnancy. Keeping in mind what her general health status is, physically as well as physiologically and emotionally. With healthcare services, is it available to her? For example, is she in a rural area? Is it accessible? Is it affordable for her or acceptable? With a patient who determines or finds out that she's pregnant, is it a pregnancy that she was planning, or was it an unplanned pregnancy? With these patients, we also have to consider, the family. Are they involved? Is the significant other someone that she knows? Are they involved? Married, unmarried? Is there other children, or the size of the family a concern? Certainly if it's an unplanned pregnancy and it's going to add one more baby, and if they already have 6 or 7 kids, that may be a stressor if they weren't planning to have an additional pregnancy. For our patients, we can't assume that they know things. So education, we need to determine what their foundation of their knowledge is, as well as their skills and understanding. Culturally, we'll be talking about that in a few minutes. Sometimes patients will smile and nod, and we think that they understand, but that may be culturally acceptable, because if they didn't do that, it may be disrespectful or rude. So when we see the head nodding and the smiling, we can't be mistaken that they understand or agree. So making sure that we have language or an interpreter or a system that we can use to make sure that we convey the proper message to them and allow them to also ask questions and to reciprocate education or skills. Making sure that they have the ability for perinatal education, so this can be childbirth class or a breastfeeding class. And are they safe at home in their environment? Do they have any exposures to, for example, black mold or any type of chemicals? Do they have any concerns in relation to their personal history? So genetics, um, culturally, are there any special considerations that need to happen during the pregnancy? Race or ethnicity, as we touched on earlier, we know that there are some that are going to be already at higher risk. With our patients' nutrition, is there any special foods that they eat and or avoid? A special dietary intake that they follow? Do they have access to food? Do they know how to make good food choices? Or are they only eating one meal a day because that's all they can afford or that's available to them? And then looking at their socioeconomic status, again, do they have shelter? Do they have food? Do they have the ability to meet their normal, just general day-to-day needs, not even including a car or transportation? Do they have health insurance? And if they don't, do they know how to initiate the process to apply for Medicaid? So these are the things that can be some of the large barriers, or we know in our research that these are hurdles that need to be overcome in order to help with our direct outcome on our patients that are pregnant and the fetal well-being. Our obstetric healthcare team help to provide our prenatal care, which again will promote our better pregnancy outcomes. In the ideal world, our patients would have been seeing their regular healthcare provider for their general annual exams, making sure that they have no concerns with pre-existing blood pressure complications or diabetes or any kind of medications that could be harmful in their pregnancy. So that would be the most ideal situation. However, since that isn't necessarily going to be whatever happens, what again we want to do is make sure that we allow for these patients who find out that they're pregnant as early as a risk assessment as possible, so that we can begin our health promotion of healthy behaviors, such as educating our patients on nutrition, avoiding smoking, including secondhand smoke. Prenatal care ideally should begin as a preconception counseling. So again, it would be an intended pregnancy. With our basic care, it's typically been provided by physicians, an MD or a DO, that is an obstetrician as well as a gynecologist. Some family practice physicians also do have the certification or the privilege to do OB care. However, they are typically what we would consider a low-risk patient, and if a patient were to have health care changes or health status change through their pregnancy, they may be referred to an OB/GYN or a obstetrician gynecologist for the following through the rest of their pregnancy. There are certified nurse midwives which have obtained their schooling and are actual nurses that attend deliveries. And we see some changes over time with this, because there is also what is called a lay nurse midwife, which is someone who's been trained on a more informal basis, and they are not a licensed certified nurse. And there are both of these types of nurse midwives who do home deliveries. So one of the things that we've seen is more patients are seeking a more natural, sometimes less invasive environment. And so because hospitals typically have the women come in and have more hands-on, some women are opting to follow with a nurse midwife, and some will even choose to deliver at home. As a certified nurse midwife in a hospital setting or in a birth center, typically a nurse midwife is with the patient throughout their time of labor. So for a physician, if any of you have ever had children or a spouse has had a child, the obstetrician will come in, they will say hello, they will check on the patient. They may be in the hospital doing rounds or surgery, but they're typically not there as a built-in support person for the patient, whereas a nurse midwife is really there throughout the labor process to help facilitate a low risk or low stressful situation. And it doesn't mean that the patient can't have some kind of medical intervention, such as pain medications if they want, but research definitely shows that for patients who have a delivery that is attended by a nurse midwife, and because of their higher participation or more actively involved in the childbirth, these patients do require fewer interventions during labor. So the statistics say that 92% of births were attended by physicians and only 7% were attended by nurse midwives. And home births are accounting for less than 1%. With our patients who are required to be seen by a high-risk doctor, this is called a maternal fetal medicine specialist, or you may hear it referred to as MFM. So M is in Michael, F is in Frank, M is in Michael. And this high-risk specialist works in a collaborative form with the gynecologist, and this specialist really is working to reduce perinatal morbidity as well as mortality. So they typically, if a patient is sent there for evaluation, they may have an ultrasound and then they will see the physician afterward. Some patients will even be seen prior to pregnancy even happening, so that they can be counseled. The term family is something that continues to change into what the meaning really is. What we do know is that family traditionally was viewed as a primary unit, and we have to consider that in healthcare because we know that it plays such a pivotal role in the direct influences on our patients, because ultimately these factors can affect our patients' decisions, compliance, and again has that effect to have an impact on our maternal and child health outcomes. With our patients who have a typical nuclear family, this is what has long been represented by the traditional American family, male and female partner, and then their children as the independents. Some nuclear families do have their extended family members, such as grandparents, aunts, or uncles, or other blood relatives, and we see this commonly with African Americans or Latin Americans. Again, we know it's an important resource that needs to be considered, especially in preventative health behaviors. With family that have a more multi-generational family, this is going to be where we have the grandparents, we have children, we have grandchildren, and parents may be caring for their parents as well as their own children. So some people will talk about the sandwich generation because they kind of have both spectrums happening. And then also another multi-generational family is that grandparents may be the ones that are supporting the children as well as the grandchildren, or as a sole caregiver. And in 2010, this was about 4.4% of the households. There are some families that have really no parent or roles, and these are the children that live independently or also in foster homes. In the terms where we see it listed as married parent families, this can include biological or adoptive. And if it states married blended families, this is usually the result of a divorce or remarriage. Something that's become very popular is cohabiting parent families. So this can be two unmarried biological or adoptive parents that live together. And another popular change that has also happened over the years is single parent families, and this could be due to a loss of a spouse, but it may also be due to divorce, separation, and this can be due to families that are vulnerable, and this includes economically as well as socially. And again, we know that this has a direct impact on health status. It affects school achievement, and typically will increase the high-risk behaviors. One of the other family patterns that we see is families of same gender, so they may live together or they may live with or without children. Uh, some will attempt to adopt, some will undergo fertility treatment, um, and that would be decided upon the partners as to who would be the one who would be, for example, if it was two females, who would be the one to actually carry the pregnancy, and that may be determined even just with chronic health conditions as to who would be the safest or the healthiest to do that. Culture plays a huge role in our care for our patients. Culture is an individual's kind of perception of their ownness, and that is influenced with religion, their environment, any kind of historical events that may have happened, all play a role in each person's behaviors or patterns of life that they choose. Cultural beliefs can be anything from what traditional foods may be, language, religion practice, healthcare, including healing practices. So whether they use modern medicine or do they practice more of like an Eastern medicine using herbal remedies. What's the person's values or attitudes, as well as their beliefs, and these are all culturally acquired and influence the perception of what illness is and if and when they'll seek health care. Culture can affect a person's reactions to an illness. It also can affect their perception of pain, as well as their expression of emotion. So if you think about a patient who is very stoic in how they portray pain versus someone who may be very verbal and have minimal to no tolerance and maybe yelling out and very loud, that has certainly a cultural aspect to that, because for some in their culture it is expected that, for example, a woman will be very stoic, or some women will not talk to anyone except for their spouse. For some, it may be the father-in-law is the one who will do all of the speaking and make the decisions for his daughter-in-law. So it is important not to assume or generalize that all persons practice every cultural belief within the group. A lot of facilities are doing a better job in trying to help evaluate any type of special cultural needs upon a hospital admission, making sure that we consider what the communication is of that individual, what their kind of space reference is. Some it could be very rude and taken in a very negative way if you are too close within that personal space, for example, like that 12 inches. Time orientation, we know that some cultures just really are kind of laissez-faire in how they even arrive to, for example, doctor's appointments. Their appointment might have been at 3 p.m., but they think it's completely acceptable to arrive at 3:45 because they still made it to their appointment, where other cultures is very driven, and they're there. They may be there very early, more future oriented, and with the cultural considerations, even what the family roles are. So are they more traditional, and that the woman is the care provider and the caregiver and does more of the quote-unquote housework things, or what are her family roles in comparison to her husband? And this, again, is changing quite a bit, especially as we have many more women in the workforce and a lot of moms and dads, or both spouses working. Again, this has an effect on how our culture would even consider that, because some may think that that's not even an option in their roles. I find it very interesting what we would anticipate the cultural beliefs and practices to be of childbearing as well as parenting through the different cultures. I think your book does an excellent job showing you that, and I would encourage you to take some time just to do some comparisons, so it will help to kind of understand some of the considerations that we may need to take specifically for each of our patients.